I've learned a lot this morning about the history of opioids and a lot of the cool things that your state's doing. So I feel like I've learned as much from you as I hopefully you guys can learn a little something from what we're doing up at Dartmouth too. So these are the faces of the opioid epidemic in New Hampshire. So there are a lot of young kids there. They're people that sort of just ended up getting hooked on opioids and dying. So this is from our newspaper, and this is what we see all the time in New Hampshire. And that's sort of what got me motivated to do something for this problem, just seeing the news every night and saying, okay, as a surgeon, I prescribe a lot of opioids. I've got to be able to do something to help with this problem. I'll go through this quickly, and we've talked about it earlier. Folks have talked about it earlier that prescription opioid deaths have quadrupled in the last 15 years. As you can see from this graph, that overdoses are now the leading cause of injury-related deaths. 19,000 die in the United States annually from this, 400 in New Hampshire. I know 700 have died in Washington last year from opioid overdoses. So there's more people than die in car accidents. So this is a major problem. And other speakers have already talked about how the link between increases in opioid prescribing with 82 prescriptions per 100 persons per year as being one of the proximate causes for this. So what role do surgeons play? Well, I think we play an important role. Although we're not, if you look at pie charts, we don't prescribe the most opioids in terms of medical specialties, but there are two ways that we can impact patients. So patients who we operate on are at increased risk of being long-term opioid users. So there was a really nice study from Stanford, actually, that people who underwent general surgical operations like breast surgery, cholecystectomies, had a relative risk that's 2 to 3 times higher than the general population in becoming chronic opioid users. So there's a risk for your individual patient. The absolute risk is relatively low. This study and studies from Michigan showed that absolute risk is somewhere probably between 2 and 5%. So it's a relatively low proportion of your patients that will actually become chronic opioid users, but it's definitely higher than if they didn't have surgery. And then obviously there's the medicines then there's the potential for diversion. So you write the prescription, you sit in the medicine cabinet, and every time I go to talk or have a meeting, someone will call to me and say, oh, that happened where I had these medications, these opioids in my medicine cabinet, and when my nephew came by and took them, or someone who was a plumber, or somebody came by and took them, and the drugs get diverted and used then by people who they weren't prescribed for. A substantial number of prescriptions written for people who die of opioid overdose are written by surgeons. And I think basically it's been summed up that this crisis will continue unabated unless clinicians stop prescribing opioids far in excess of the clinical need. So what's the problem for clinicians? Again, there's this tension between the concern for the individual patient and the responsibility for population health. So for the individual patient, there's a tendency to overprescribe. We all want to be good doctors. Surgery hurts, it causes pain. We want to minimize acute postoperative pain. And we really want to avoid the need for patients to have to return to the clinic for a refill prescription. So that's what, before we could e-prescribe, which just came out recently, we really could do a phone call and prescribe more opiates. So people, especially if you're in a rural state like Washington or New Hampshire, people have to drive 2 hours back to get a refill on their prescription. The attending will just tell a resident, hey, just give them enough that their pain's taken care of and they don't have to come back to the clinic for a refill. But on the other hand, we have responsibility for population health, and we want to minimize diversion, overdose, and addiction. And we need to limit our prescriptions and really provide patients with the lowest practical dose. But what is the ideal number to prescribe? Well, that's what's going to be focus of the rest of this talk. So basically, when I started thinking about this just a couple of years ago, we did a literature review, and really there are very few studies that address the optimal postoperative opioid prescriptions. There was just literally those 4 papers in some urology, some oral, hand, and upper extremity studies that had looked at what's the right number of opioids to prescribe patients. There were no studies, 0, looking at best prescribing practices in general surgery. So I said, okay, we need to figure this out. So what I'm going to describe to you then the rest of the talk is basically work from 3 different papers that we two different papers that we published. This one we just sent in last week, and I'll give you the data from that one also. But basically, this paper has been published in Annals of Surgery. This one's in press. You can find it if you just go to the Annals of Surgery website. It's to be published. It's electronically published. It just hasn't come out in the print edition yet. And then this one, like I said, we've just sent in. It's basically been a collaboration between a couple of surgery residents, Maureen Hill and Ryland Stuckey, a medical student, Michelle, and one of our data managers, Julia, and we've just kind of put this stuff together. So our objective was to first describe the prescribing patterns of postoperative opioids were for common general surgery cases at Dartmouth, and then identify an ideal number, and that's in quotes, of pills to prescribe. So we first started just looking at the 5 most common outpatient operations that we did at Dartmouth between June and December 2015. And those were partial mastectomies, mastectomy with lymph node biopsy, lap choles, lap inguinal hernias, and open inguinal hernia repairs. And basically, we just, we have a data analytics institute that we could get information on opioid prescriptions for these patients and their refill data. And then we basically we called patients and found out how much they used. Patients with recent opioid use within 30 days of the procedure or a history of opioid abuse, and those with postoperative complications were excluded. So we weren't sure how to handle patients who have been chronic opioid users, and I think that's still an ongoing issue for us to grapple with. So again, it's very simple. We just called patients, asked them how many they took. In the beginning, we sort of did some estimating. As the studies have gone on, we got very much more specific. We actually sent people letters first, asked them to count the number of pills in their bottles, which people invariably keep. Almost no one throws these out. They're just sitting there so they could count the pills and tell us exactly how many they used. And just for ease, we just said 1 pill was a 5 milligram oxycodone. That's about an 8 morphine equivalence for people who think in the morphine equivalence. Okay, so we had about 700 cases then of, that we looked at in this initial study. We excluded about 8% of our patients either because of chronic opioid abuse and 5% or complications and 3%. So we analyzed about 640 patients. So here are the 5 operations on the top of this tables. This is partial mastectomy in lymph node, lap chole, lap inguinal hernia. And almost everybody got a prescription for opioids, which is kind of interesting. And the mean number of opioid pills prescribed was about 20 for the partial mastectomies and over 30 for the lap chole, lap inguinal hernia, medians 20 to 30. And look at this range. The range went from, 0 to 60 here, 15 to 120 after an inguinal hernia repair. Okay, a huge range in how many were prescribed. Okay, no one knows how many, no one knows how many to prescribe. So we found there was a lot were being prescribed, and it was a huge range. So I'm going to show you a few slides here where basically this is the opioids prescribed then are going to be on the top here. Okay, and you can see this is the percent of the total population on the y-axis, and on the x-axis it goes from 0 up to, say, 50. This is for partial mastectomies. Okay, people had a lumpectomy. And then the next slide will show how many they actually used. Okay, so you can see here then that, hopefully you can see these numbers in the back, but about 75% didn't use any. Okay, and almost everyone used less than 10. But you can see the difference between here and what was actually used. Okay, and I'll just kind of scoot through these for each. Here's partial mastectomy with sentinel node biopsy. That was what was prescribed. That was what was used. Again, almost everyone less than 10. Lap choles. Here's what was prescribed. Some people got 90 pills, 100. Here's what was used. Okay, 84% had less than 15 pills that they used, and a third didn't use any. Lap inguinal hernia repair, again, here's how many were prescribed. This is 20 to 40, if people in the back, if you can't see that. And here's how many were used. Open inguinal hernia repairs, most people were getting 30 there. And here's how many were used. Again, most people less than 10. So only about a quarter, if we calculate out about how many of the pills were actually taken, it was about a quarter of the pills that were prescribed. So for all these operations, this many pills were prescribed. About 28% were actually taking, leaving 71% of the pills unused. So to calculate the ideal number of pills then, we basically determined the number of pills that would fulfill the opioid use of greater than 80% of our patients. So this is the lab-Coley example then. Here's where 84% of the patients would have all their opioid requirements filled if you gave them 15. So basically, we then came up with a guideline or a recommendation. So for the partial mastectomies, we just give them 5. Partial mastectomy, sentinel node, 10, and for these other 3 operations, 15. So it's a little different based on the operation with these outpatient operations. These then were our guidelines or our recommendations compared to the median number of pills that were actually prescribed to our patients in that preceding 6-month period. So you can see it's about half or less that we'd end up recommending prescribing. So you say, well, just hypothetically, how many pills would be prescribed if we prescribed the ideal number rather than what was actually given? And if we looked at all the cases, there were 17,000 pills prescribed. And if you use the ideal number, you would have prescribed about 7,000. And so that basically saves about 9,807 pills less available out there for diversion, or about 57% decrease in the opioids prescribed. All right, so those are our our guidelines. And so we published that paper, but then it was like Ginny was just talking about before. Her group the briefing can give recommendations, right? But how about implementation? Well, how do we implement this, right? So I'm section chief of general surgery. I don't have that much influence, but so it isn't like I can tell everybody do this and they'll absolutely do it, But basically, I presented. I wish it were like that. It isn't really like that at Dartmouth. But anyway, we presented this use and this use data and the guidelines at grand rounds, at my section meeting. Sent emails to my faculty, had teaching sessions with the residents where we presented the data, as convincingly as we could in April and May of 2016. And so we just gave that very simple guideline for those 5 operations. And then the other things we talked about was we recommended using acetaminophen and ibuprofen first, and then opioids. And this is based on really work from Cochrane analyses. So and that reference is down the bottom here, but basically, the Cochrane analysis is this think tank over in England where they do really good reviews, I think, of the literature. And they basically did one review. They said, well, what % of patients will have at least 50% of reduction in acute pain for 6 hours? And if you use ibuprofen and acetaminophen, about 3/4 of the patients will have at least 50% reduction in their pain for 6 hours. So, ibuprofen alone, about half. Oxycodone alone, only about 23%, which is just barely better than placebo. So oxycodone isn't even really a very good medicine for acute pain. And ibuprofen and acetaminophen are way better. So basically, I kind of talked to everybody about this. Gave patients information sheets on doses of the acetaminophen and ibuprofen to use, which are pretty standard. Everybody knows what those are. And then also just sort of set the expectation. So whenever I urge my colleagues to do this too. So when you see patients, in the office, when you're talking to them about the surgery, when the preoperative holding area, right before you take them to the OR, you just kind of go over and say, all right, I'm going to be doing partial mastectomy sentinel node on you for your breast cancer. And I can say, I've studied this, and over 90% of my patients don't need any opioids for this. So I'm not going to give you any opioids because I really don't think you're going to need them. And you basically set that expectation in patients so that and then they'll say, oh, well, I don't want any anyway, or whatever. It's the most common thing I get. So if you set that expectation, you tell them you're going to take, the ibuprofen and acetaminophen, and then you can, potentially prescribe the amount of opioids that we recommend. And that was sort of the guideline we gave to the residents and the faculty. And then basically we just, we didn't tell anybody to do this, we just observed the opioid prescribing patterns for the next 4 months and collected the data by paper forms and a phone survey. And so this is what happened. So in those next 4 months, we did those same 5 operations. We developed the data, we brought the data together the same way we had in our initial study. Again, some were excluded for the opioid use or complications. Analyzed about 224 patients. Many were given opioid prescriptions. That's what the guidelines called for giving them some opioids anyway, although less. Okay, and here's a key slide, all right? So here's what happened then, pre versus post. So here are the operations here. Here's the mean number of opioid pills that were prescribed before I educated everybody about the guidelines, et cetera. So it was like 19, post it went down to 5, 23 down to 9, 35 down to 19, 34 down to 19, 33 down to 18. All were highly statistically significant for every operation. The median number also decreased dramatically, and the range was much less. Okay, so here we're going from 0 to 100, we're down to 0 to 40, from 15 to 120, down to 0 and 40. So the total number of pills that was prescribed and the range were much, much tighter after simply just telling docs about what they should prescribe. Just telling them how many the patients use. We didn't have to enact any laws. I wasn't fining anyone or taking any money out of their salaries or anything like that. I just, because there was no incentive for the docs to give them more. You know, they just needed to know how many to prescribe. You know, in both, and so, I mean, that was it. So the total number of pills then that was prescribed decreased. So this slide shows that for each operation then, the percent decrease, it varied a little bit. A lot of these partial mastectomies and sentinel node biopsies really went down a lot. But overall, there was about a 53% decrease in the total number of opioids that were prescribed to our patients. All right, how did the patients suffer? Okay, so you know, we were only giving them enough opioids to take care of 80% of the patient's pain. So how about the other 20%? You know, I called the nurses in my clinic. I said, oh, you guys might get a lot of phone calls because patients, you know, might not be getting enough opioids, and you know, you just be ready for this and everything. But Lori, my nurse in my clinic, said it wasn't a problem. It wasn't a problem at all, frankly. So here's what happened with this. So we ended up getting pain use data on about 2/3 of these 224 patients. They still only took 34% of the pain pills that they were given. So, you know, before it was about 28% or so, 27% something. Now it was 34%. So still, we were overprescribing, okay? But the answer is yes, they did get their pain taken care of because only 1 out of the 224 patients needed a refill on their opioids, okay? So it wasn't like, you know, we were under opioid prescribing anybody. 1, less than 0.5%, okay, of these patients needed an opioid refill. Okay, so how about, so we did look at the people who were prescribing a little bit in excess of the guidelines. So about 30% of our patients were prescribed more pills than we recommended in the guidelines. A total of 34 providers wrote prescriptions, 6 attendings, 27 residents. There was no real difference there. But actually 4 providers wrote for half of all the excessive prescriptions. So I fired all of them. No, just kidding. No, but one of them was one of the minimally invasive surgery fellows, and she came on like a month later, so she missed all the educational stuff and just, boom, started prescribing what she had been prescribing as a resident, and it was way over, and et cetera. And so we kind of found out who that was and you know, talked to her about this and everything. But so it was just a small minority of people who were writing for a lot of the excessive prescriptions. How about, well, we also, when we called and talked to patients, we also asked them about non-opioid analgesics and what they use. So here's the chart that shows what they use. So this is the percent of patients on the y-axis here, and this is after partial mastectomy, okay? So in this black box here are no opioids. So again, about 75% of the patients didn't use any opioids. In the purple is acetaminophen or a nonsteroidal, and 100% of them used either acetaminophen or ibuprofen. It's pretty good. Both acetaminophen and the nonsteroidal, which is like I talked to you about the Cochrane analysis, that was the group that really did well. We only got about 40% of them taking both, okay? And then no one was taking an opioid only, which is pretty interesting. You know, just for another representative operation after laparoscopic cholecystectomy, only about 25% use no opioids, about 60% use acetaminophen or ibuprofen, only about 15% use both. Some were still using opioids only. So the message wasn't getting out there as effectively, I think, to everybody as it could have been. Anyway, so here are the conclusions then from this second study then. Basically, just this educational intervention resulted in a marked decrease in opioids prescribed for 5 general surgery operations. We were able to decrease the pills by more than half. All 5 operations showed a decrease in the pills, and there was much less variability. And the patient pain was not worse. And that most of these patients are using either acetaminophen or a nonsteroidal. And we still have an opportunity to do better because only about 20% overall use both acetaminophen and the ibuprofen. All right, so there's still a big group of patients then that I operate on who we haven't addressed yet, and those are people who are inpatients after surgery, okay? So, you know, how many do you prescribe to them? And no one knows, okay? Again, this hasn't been studied. No one's written, there are no papers on this, okay? On how many, so I've done a colectomy on someone, or I do liver and pancreas surgery. I take a tumor out of someone's liver. You know, they're in the hospital for 3 or 4 days, and then send them home. How many do I send them home with? Well, you know, in New England, you know, there are laws, okay, that limit the number of pills prescribed to a 7-day supply. Actually, New Hampshire is missing because we don't have that law, but the other states in New England do. But there's ambiguity to this. I'm a very practical person as a surgeon, right? I want to know exactly what to do, right? I'm doing these precise operations. What is a 7-day supply? Is it 21 pills, 1 pill every 6 hours while you're awake? Or is it 84 pills, 2 every 4 hours because you're up all night with pain? I don't know how many it is, a 7-day supply. Do you assume the patients will use less pills every day? Do they start by taking 2 every 4 hours and then taper down to 1 every 4 hours? I don't know. Is 7 days the right number, or is it 3 days or 5 days or 10 days? I don't know, right? So I just personally find this ambiguous, okay? So I don't, hopefully it doesn't bother anybody, but it's just, it's hard because you don't really know how many to prescribe, okay? All right, so what do we do? So we looked at 6 common inpatient operations then that we did just July through December of last year. So there was bariatric surgery, some laparoscopic foregut surgery, liver surgery, pancreas surgery, colon surgery, and ventral hernia repairs. And we excluded, again, then people who had major complications, people who were chronic opioid abusers, and we excluded people who were discharged to a rehab facility because we really couldn't get data on exactly how many opioids they use at the rehab center. So then we sent everybody a questionnaire and asked them about their opioid use, and whoever didn't return the questionnaire, we called, and we kept calling them until we got their results. So a total of 333 cases, about 99 were excluded for either opioid use or complications. So about 230 were analyzed. This is how many pills were prescribed. And here's our mean number of pills. These are when they're discharged. So between 15 and 30 kind of medians, between 10 and 20. But a big range again. You know, here's 6 to 105, 0 to 70, 0 to 252 after their colectomy. You know, I didn't write that one. I'm not sure who wrote that one. Again, most of the patients are going home with prescriptions, so about 85% overall went home with an opioid prescription. This was after everyone's aware of this, you know, and stuff too. This is just this is less than a year ago. So this, like I said, this stuff isn't published yet. So, all right, we were able to track down the opioid use in 90% of the patients. So I was really happy about you know, that yield. It's not like we were missing very many there at all. And we looked at, again, about 38% of the pills were taken, and about 6% overall ended up needing opioid refills. So it varied a little bit, but about 6%. Okay, so how did we analyze these groups? So we broke them into 2 groups. Some people were discharged on post-op day 1, and some were discharged on post-operative day 2 or greater. And what we said is, all right, we just looked then at how many they used at home for this group. For this group, we had data on how much opioids they used the day prior to discharge, okay? This is really obvious, right? No surgeon, if there are any, I know we have at least one surgeon in the room, right? How many surgeons do we have in here? Yes, okay, all right, we got some surgeons, good. I hope everyone, so this is, you know, this is not gonna come any surprise to any surgeon, right? Is to say that the number of opioids you use the day before you're discharged, well, maybe that will predict how many you're going to use at home. Okay, so it's nothing brilliant or anything, but it's just trying to figure out exactly what's going on. So here's the people that were discharged on post-op day 1. So these are a lot of the patients who were having the bariatric surgery or the laparoscopic Nissen fundoplications or some of the lap hernia repairs. That's what mainly constituted this group. And here's again the percent of patients, and here's how many pills they used at home. So it's 0, about 43%, 22% used none. 1 to 5 was about 20%. So 15 pills took care of over 85% of them. Okay, there were just a few outliers here who ended up taking more than 15 pills if you're discharged on post-op day 1. Then we did a univariate and multivariate analysis of factors associated with outpatient opioid use for patients discharged after postoperative day number 2. Okay, one more. All right, and that's what this, so it's a big slide. We'll just kind of go through this a little slowly. So the variables then are here. So we've got so the age, either less than 60 or older. And these are the pills taken after discharge, the mean number of pills. So if you're less than 60, the mean number was 13. If you're over 60, mean number was 4. Okay, and we can see that that p-value was highly statistically significant. So old people took less pills than young people. All right, how about men versus females? But no one would have guessed this. Okay, so actually the men ended up using a little bit less than the females. It was statistically significant just because we had pretty big numbers. Then there's length of stay. So if you were in the hospital for just 2 days, you went home with more than if you were in for 3 or more days. That was statistically significant in univariate analysis. The use of Tylenol or ibuprofen was not statistically significant, although the use of both trended. It was equals 0.07 actually. And then here's the most important one on the bottom. Oh shoot, the very bottom of this is cut off. I can't believe that. All right, so the number of pills taken the day prior to discharge, if it was 0, the mean was 1. If it was 1 to 3, it was 8. And if it was 4 or more, it was 21. Okay, I'll just tell you that. And, and that was highly statistically significant. And then if we looked in multivariate analysis, this was the most important predictor. The number of pills you took the day prior to discharge was the most important indicator of how many pills you were going to take at home. Also, age was, in multivariate analysis, important. But note that the type of surgery was not statistically significant, either univariate or multivariate analysis. So it didn't matter whether I did a colectomy, a liver resection, hernia repair, pancreas, bariatric foregut. It didn't matter what type of surgery we did. It just mattered the most was how many pills they took the day before discharge, which makes it a lot easier to remember, okay? So you don't have to know what kind of, it doesn't care what surgery it is. It's just ask how many did they take the day before they were discharged. Okay, so here's the granular data on patients who had no opioid, they didn't take any opioid pills taken the day prior to discharge. How many did they take at home after discharge? Well, 85% took none. Okay, there was a smattering of people who took a few opioids after they went home. 1 to 3 opioid pills taken the day prior to discharge. 37% didn't take any when they went home. 85% took 15 or less. If you took 4 or more opioid pills a day prior to discharge, then 30% took 85% or less after they were home. So basically, we could come up then with a really simple to derive and easy to remember guideline on how many opioids to prescribe when someone was discharged. So if you were discharged on post-op day 1, didn't matter what operation you had, just send them home with 15, takes care of 85% of the patients. Discharge on post-operative day 2, you just look at the pills used on the day prior to discharge. If it was 0, send them home with 0. 1 to 3, send them home with 15. And greater than 4, send them home with 30, and you'll take care of more than 85% of the patients. So what would be our potential savings if we did this? So about 40%, we'd be about a 40% decrease in the number of opioids that were prescribed to patients if people followed this rather than what we had done the 6 months before. Now, I think that these guidelines will likely overestimate the home opioid needs, for several different reasons. One is that if we only about a quarter of our patients were using both acetaminophen and ibuprofen, because obviously there's some people who ibuprofen's contraindicated, they have renal failure or whatever, and you're not going to use it on them. But most patients can take this, and only 28% in our study use it. I think if more people use this, you could even drop the number prescribed lower. In the elderly, you can just prescribe them less. They use less. It's clear from our multivariate analysis they use less, so you don't have to give them as much as even our guidelines just said. You could also set the bar a little lower. We were setting the bar at taking care of 85% of the patients, right? Well, what if you set the bar at 67%, okay, or 65%? If you set the bar there, then to satisfy 65% of the patient's needs, then you can decrease the number prescribed actually by 60%. Okay, so you'd even, instead of just 40%, you get 60% lower if you set it at 65%. And like I said, you might get some patients coming back or calling, and maybe you have to e-prescribe them an opioid or something, but it's I don't think you're going to see much based on our earlier experience when we only prescribed to take care of 80% of the patient's needs. Then the other interesting thing is that what do the people, let's see, a lot of people are using opioids for non-surgical pain indications. So we called the outliers, okay? So we called them back, all right? The patients who took more pills than the recommended prescription amount, okay? So that the amount that we thought, okay? So it was recommended, we called them and said, well, why were you taking this opioids? And we asked them, why are you taking them? So let's see, so 47% were taking them because they still had pain at their incision or whatever. 18% were taking them so they could sleep. 14% took them just because the doctor wrote me a prescription for 20 opioids, and I think I was supposed to take all 20 of those opioids, basically. It's like your mom says, here's dinner, you have to eat everything on the plate, okay? It's one of those things. 7% took it for non-surgical pain, fear of pain, indigestion, whatever. So, only even of those 40 that took, the more than recommended amount, half of them were taking them for non-acute surgical pain issues. So I think that the guidelines are actually pretty conservative, frankly. All right, so our conclusions then on inpatient prescriptions is the strongest predictor of home opioid use was the inpatient use the day prior to discharge. Use at home after inpatient admission was independent of the operation performed. We established a guideline for discharge opium prescribing that's easy to use and to remember. And use of this guideline will greatly decrease the number of opioids prescribed and will still take care of patients' pain. We're not going to have a bunch of patients in pain because of this. All right, the other side of this then is, well, what happens to the excess pills? Okay, so the patients have gone home and they've just, we called them and they counted and they had 25 pills left here. What do they do with them? So we asked patients, part of this questionnaire, well, what did you do with them? And in our first outpatient study, 9% approved of them disposed of them in an FDA-approved fashion. So they took them back to the police station or the fire station and dropped them in the drop box. Or we even allowed them to sort of dissolve them in water and mix them with kitty litter and throw them in the garbage in an unmarked container. Okay, so so that was about 9%. And then in our inpatient study 1 year later, it went up to 19%. So it doubled the amount that disposed of them in an FDA-approved way. And I think we still can do much better at educating patients as to what things are, but we tried, in that intervening period to educate patients better and to try to get them to dispose of them this way. But this is still, I think, a huge, so one way is to just cut down the number of opioids that are prescribed overall, but also I think this is a big issue with regard to making sure that the pills that aren't used end up getting disposed of accurately, so they're not diverted to other people, to be misused. And I think even in our second studies where we prescribed less, only 38% were being actually used. So this is still a lot of pills that are out there, and I think this is a second important thing that needs to be worked on if we're really going to optimize the appropriate use of the opioids. So this is where I work, and the leaves are starting to turn in New Hampshire right now. So I just wanted to thank you for your attention. I'm happy to answer any questions you might have.